नमस्कार, मैं डॉक्टर मानसी हूँ। मैं राजीव गांधी कैंसर इंस्टीट्यूट में कंसल्टेंट मेडिकल ऑन्कोलॉजी हूँ। आज का दिन काफ़ी ही अच्छा है। आज त्योहार है। आज काफ़ी जगह देश में एक किस्म से एक अच्छाई की जीत के बारे में ही आज जश्न मनाए जा रहे हैं। तो आज का हमारा टॉपिक भी कुछ ऐसा ही है। जो इन्फेक्शंस कुछ जो कैंसर को कॉज करती हैं, उनको कोशिश करके पहले ही खत्म किया जाए या आगे उनको कैसे प्रिवेंट किया जाए। दैट इज इन्फेक्शंस कॉजिंग कैंसर, निपिंग इविल इन द बड। सो आज के लिए जो प्रेजेंटेशन है वो डॉक्टर सीमा गुलिया करेंगी, जो प्रोफेसर हैं मेडिकल ऑन्कोलॉजी में टाटा मेमोरियल हॉस्पिटल में। मैडम इज वेरी वेल नोन। उन्होंने बहुत सारा ट्रायल्स भी कर रखा है इंडियन सेटिंग में, और काफी अंतरराष्ट्रीय लेवल पे भी बहुत सारा डेटा पब्लिश किया हुआ है। शी इज फैंटास्टिक एंड आई पर्सनली हैव हैड द प्लेजर ऑफ वर्किंग विद हर एंड वेरी फॉन्ड मेमोरीज। डॉक्टर सीमा आज कहीं पर है जहाँ पे थोड़ा नेटवर्क का इश्यूज है, तो उन्होंने अपना एक प्री रिकॉर्डेड प्रेजेंटेशन दिया है। वो हम अभी प्रेजेंटेशन आपको दिखाएंगे और उसके बाद शी विल बी अवेलेबल आगे क्वेश्चन एंड आंसर सेशन के लिए। सो हम शुरू करते हैं। लेट्स स्टार्ट।
Very good afternoon to one and all. At the onset, I would like to thank the organizers for having me here. Today, I'm going to talk about infection causing cancers, nipping the evil in the bud. So, the cancer caused by infectious agents presents unique opportunities for their prevention and treatment. Therefore, a clear understanding of the epidemiology of infection-related cancer, the natural history of infection-related cancer, their pathogenesis is crucial to plan their preventive strategies. And this is how I'm going to talk today about the infection-related cancers. There has been significant increase in the number of oncogenic pathogens that have been designated by the IARC. Of these, the most common infectious agent that contributes to more than 90% of the infection-related cancers are H. pylori, HBV, and the HCV infection. The remaining oncogenic pathogens constitute less than 10% of the infection related to cancer. There has been significant disparity in the incidence of infection-related cancer between the developing world and the developed world, where the infection-related cancer constitute around 25% in the poor countries and 7.5% in the high-income countries. This reason is because of there is diversity in the endemicity of infection according to the geographical area. For example, HPV infection is prevalent in the poor income countries and H. pylori infection is prevalent in the high income countries. Moreover, there is significant disparity in availability and access to the treatment for both cancer as well as the infectious agent, and these two factors are the main causes of difference in the incidence of infection related cancer that is seen across the globe. According to the Globacon 2018 data on incidence of cancer and mortality, it was estimated that 2.2 million infection attributable cancers were seen, and these were because of the 4 most common oncogenic pathogens that I have elucidated in the previous slide. If we look at the H. pylori infection and related cancer across the globe, this H. pylori related gastric cancers are more prevalent in the Eastern Asian countries as well as in Latin America. Similarly, if we look at the HPV related cancer, these are more prevalent in the sub-Saharan countries, few of the Eastern Asian countries, and few of the Latin American countries. Majority of the cancer that is associated with HPV related infection is the cancer of the uterine cervix. The HPV related cancer are also seen in head and neck primary, and HPV 16 and 18 are the most common subtype that are associated with the cervical cancer. However, other high risk subtypes like HPV 6, 11, 31, 33 are also being associated in close to 20% of the cervical cancer. These are the important characteristics of infection-related cancer, which are the presence of chronic infection, the age at which infection occurs, and this usually happens in the first or the early second decade of life, co-infection with other pathogens which affect the competency of the immune system are also a characteristic feature of infection-related cancer. The infectious agent causes cancer by three main mechanisms. First is the presence of chronic inflammation that leads to DNA, protein, or the membrane damage and leads to increased gene expression changes and increased cell proliferation. And this was seen in relation to H. pylori, HCV, and various parasitic infections. Second important mechanism is the induction of second important mechanism is the virus-induced transformation, that is because of integration of viral genome into the host genome that leads to activation of oncogenes and inhibition of tumor suppressor gene, which leads to uncontrolled growth of a cell. And third important mechanism is the immunosuppression that is seen with either the co-infection or because of the oncogenic pathogen itself, which leads to which helps the cancer cells to evade the immune response and so that they can proliferate independently, and this uncontrolled proliferation leads to the cancer formation. The type of infection and the type of immune response that happens throughout the human life also is associated with the risk of cancer. Certain infection leads to stimulation of immune system and thus they prevent cancer, and these are mainly seen in the early childhood days. Temporary infection, immunosuppression, and low-grade inflammation and immunosenescence that happens with the increasing age, it associated with increased risk of cancer with the increasing age. Various interaction has been shown with infectious agent along with the oncogenic agents that leads to the persistent inflammation and thus the formation of cancer. For example, presence of P. falciparum infection leads to decreased activity of T cells against Epstein-Barr virus infection, and this Epstein-Barr virus infection suppresses the B cell, and thus P. falciparum is also being protected against the B cell. So this co-infection with oncogenic pathogens with other infectious agents is also one of the important mechanisms that leads to formation of cancer. So there are three main primary strategies for the prevention of infection-associated cancer. The first being the primary prevention. The aim of primary prevention is to eradicate the chronic infection, and this is usually done with the help of a vaccine. Secondary prevention, the aim here is to detect the disease in early stage in situ disease before the invasion happens. And tertiary prevention, it aims and it addresses the cancer patient after therapy, and here the aim is to prevent local and the distant relapses. Now I'm going to discuss individual oncogenic pathogens, their pathogenesis and preventive strategies. The first and foremost is the HPV related infection and cancers, and because this is prevalent in low middle income countries as well as it is prevalent in India too. We all are aware that majority of the HPV related infection, they clear within 6 to 18 months of their acquisition without any signs and symptoms. Approximately 40% of CIN2 lesion also regress spontaneously. So only 0.3 to 1.2% of initial infection will progress to invasive cervical cancer, and HPV 16-18 subtypes constitute majority of the cervical cancer cases. This is the pictorial presentation of HPV genome. This HPV virus, it expresses early genes and late genes during the replication of the viral cycle. The HPV gains access to the basal epithelial layer through microabrasions, and as this virus proliferates and integrates with the host genome, the various genes are expressed, and ultimately the virions encapsulation happens in the superficial layer, and these are released and they are ready to infect the other cells. The molecular events that happens during the progression to cervical cancer carcinogenesis includes the persistent high-risk HPV infection, which leads to integration of HPV into the host genome. And after their integration, there is overexpression of oncogenes, predominantly E6 and E7. E6 suppresses the P53 and leads to uncontrolled proliferation. It inhibits apoptosis, and it also activates other signaling pathway that leads to uncontrolled proliferation of cells. E7 inhibits the retinoblastoma gene, and thus it inhibits the checkpoint from G1 to M stage, and therefore there is increased cell cycle deregulation and increased proliferation of cell. And E7 also causes various demethylation as well as chromatin remodeling that leads to genomic instability, and uncontrolled cell proliferation ultimately leads to carcinogenesis. So how can we prevent cervical cancer? The primary prevention includes vaccination of girls between 9 to 14 years of age, increased health education among the teenagers that includes health information about tobacco use, sexual education tailored to the age and culture, more and more education regarding the safe sexual activities. Secondary prevention, it targets the women who are more than 30 years of age, and the hair screening for cervical cancer plays an important role. Tertiary prevention includes treatment of invasive cervical cancer, and that is done with various modalities depending upon the stage of disease, like it could be surgery, radiation therapy, or the chemotherapy. So these are the three common vaccines against HPV infection: the bivalent, quadrivalent, and the nonavalent vaccine. The dose recommended is 0.5 ml per dose. Usually 2 to 3 doses are given, and these vaccines have shown efficacy against the HPV related precancerous lesions. These are the 4 important phase 3 trials that looked at the efficacy of HPV vaccine in the young girls and women. These include Future 1, Future 2, PATRICIA, and the Costa Rica vaccine trial. An important point to note here is that in all these trials, the primary endpoint was the prevention of precancerous lesion, namely CIN 1, 2, and 3, and HPV-related genital warts. And these precancerous lesions are thought to be surrogate endpoints for the invasive cervical cancer, because we all are aware that from the time from onset of HPV infection to the development of cervical cancer, it is anywhere between 25 to 30 years. And therefore, the surrogate endpoints are used in the clinical trials so that we can have early results. This is a long-term follow-up data from the Costa Rica vaccine trial, which has shown that at 11 years, vaccination against HPV has shown cumulative vaccine efficacy of 97% against CIN2, and the vaccine efficacy is 94% against CIN3. And this is the longest follow-up of any HPV vaccine trial. This is a combined analysis of PATRICIA and Costa Rica trial, which has shown the efficacy of bivalent HPV vaccine, and it showed that the incidence of CIN2 and CIN3 was significantly lower in HPV vaccinated population compared to the control group. This is the only study which is recently published in NEJM where the investigator looked at the cumulative incidence of cervical cancer due to HPV vaccination. So this was a study done from the Swedish Health Registry. Herein, 1.5 million girls and women between 10 to 30 years of age, they were followed up, and they were divided into 2 groups. One is the unvaccinated group and second is the vaccinated group. Both the groups were matched for their age at the last follow-up, their socioeconomic condition, their education level. As you can see clearly, the incidence of invasive cervical cancer was significantly higher in the unvaccinated population, and it was lowest in vaccinated population, and specifically when the vaccination happened at the age which was less than 17 years. Benefit was also seen in women who were vaccinated between 17 to 30 years of age, but there the benefit was much less as compared to women and girls who were vaccinated below 17 years of age. There is also a Cochrane review on the efficacy and safety of prophylactic HPV vaccine, and this Cochrane review included bivalent and quadrivalent HPV vaccine. This review did not include nonavalent vaccine, and this is because in all trials where nonavalent vaccine is used, the comparator arm was the quadrivalent vaccine. And in this Cochrane review, the aim was to look at the efficacy of HPV vaccine between vaccinated and unvaccinated group. So this review highlighted that the bivalent and quadrivalent HPV vaccine induces excellent protection against persistent HPV 16 and 18 infection and associated precursor lesions. The vaccine efficacy was highest in women who were younger than 25 years of age. Therefore, teenagers should be the first target for HPV vaccination campaign. This review also suggested that vaccine efficacy estimates are lower for women who were already infected with HPV infection, and the efficacy of vaccination decreases with age. Important point that was highlighted by this review was that there was a similar rate of serious adverse event between the experiment and the control arm. However, there are certain challenges in introducing HPV vaccination at a national level. The first and foremost being the efficacy of the HPV vaccine. All the major trials have proven the efficacy of HPV vaccination against CIN2 and CIN3, but not against the invasive cancer. And as I have alluded earlier, that 40% of CIN2 regresses spontaneously. So we need a long-term follow-up data on these trials to look at the incidence of invasive cervical cancer, and then the data will be more robust and in that case we will be more comfortable in advising HPV vaccination. There is perceived risk of side effects with the HPV infection in the general population, the most common being premature ovarian failure and infertility, and the Guillain-Barré syndrome, which has been reported in earlier HPV vaccine related trial. Cost is quite significant, is also one of the common reason for non-adoption of HPV vaccination at a national level. And healthcare infrastructure, basically we need to improve the healthcare infrastructure so that the HPV vaccination can be included as a part of national immunization program. So world over, around 100 countries have already included HPV vaccination in their national immunization program, and this is more so in the developed countries and the low middle income countries and poor countries where HPV infection is more prevalent and incidence of cervical cancer is higher. There it has not been introduced because of the poor health infrastructure. Moving ahead to the screening for cervical cancer, which is basically the secondary prevention against cervical cancer. The recommended age and frequency of screening for cervical cancer in affluent countries is between 25 to 65 years, and it is recommended to be done every 5 years. In high middle income countries, the recommended age is between 30 to 65 years, and if 2 consecutive negative tests are seen at 5-year interval, then it should be done at every 10 years. In low middle income countries, screening for cervical cancer should be done between 30 to 49 years of age and every 10 years. And in poor countries, it is recommended that at least 1 to 3 times per lifetime screening should be done between 30 to 49 years of age. So what tests should be utilized for the screening? The ideal test is cytology by pap smear and HPV DNA testing, which is recommended in all resource setting. The co-testing includes cytology along with HPV DNA testing. However, in low middle income countries and poor countries, visual inspection with acetic acid is also been advocated, and it has shown to reduce the incidence of cervical cancer. And on similar study was done by Dr. Sastry et al. At Tata Memorial Center, Mumbai, where the investigator looked at the efficacy of VIA screening by primary healthcare workers. And it was a randomized controlled trial where the population was divided into 2 groups. One group received cancer education followed by screening by VIA, and it was then a 2-year interval. And second group received cancer education and no screening. And both the groups were then followed up for the incidence of HPV-related precancerous as lesions as well as invasive cervical cancer and mortality. So at 12 years of follow-up, it was seen that the incidence of cervical cancer was lower in the screen population compared to the control group. And there was significant reduction in the incidence of mortality due to cervical cancer in the screen group compared to the control group. There are well-recommended flow charts and management guidelines available for individuals who undergo screening, and based on the results of screening tests, the individuals are then recommended for further screening, recall testing, as well as if it is CN2 or 3, then treatment related to these cancer. And there are well-defined guidelines that needs to be followed up for that. So the aim of secondary prevention is to timely detect the cervical cancer at an in situ stage before they become invasive. So high screening coverage and an organized screening program is vital for secondary prevention of cervical cancer. So ideal program for cervical cancer prevention, particularly in a low middle income countries, is vaccination of adolescent girl before they get infected with HPV virus. And second is screening of women between 30 to 45 years of age and at least 1 to 3 screens per lifetime. This is a modeling analysis which is being developed for low middle income countries, and it looked at the dynamics of cervical cancer incidence after HPV vaccination and cervical cancer. This red curve denotes the incidence reduction in the incidence of cervical cancer with vaccination and 2 lifetime screens. And aim here is to achieve the cervical cancer incidence to less than 4 cases per 100,000 women a year. And the green bar represents the incidence of cervical cancer with vaccination only. So the aim is that by the year 2080, there should be at least 85% reduction in the incidence of cervical cancer. And that can be achieved with vaccination strategy and with the cervical cancer screening. Moving ahead to another important oncogenic pathogen, which is the HPV hepatitis B virus. HPV infection usually happens in childhood, which if untreated can lead to chronic hepatitis B infection, which can lead to hepatocellular carcinoma. So primary prevention includes universal HPV immunization and screening of blood products and avoiding risky behavior. Secondary preventive strategies include treatment of viral hepatitis, and nowadays effective treatment modalities are available for the treatment of hepatitis B infection. In patients who have developed hepatocellular carcinoma and those who are still HPV positive, treatment of viral hepatitis has shown to reduce the incidence of recurrence after the treatment for HCC. This is the study which was done in Taiwan and which has shown that with the use of HPV vaccination at birth, there has been significant reduction in the incidence of HPV-related hepatocellular carcinoma. So universal hepatitis B vaccination is the most important way to prevent HPV-related HCC. Another important way of transmission of HPV infection is from mother to child. Therefore, to prevent that, prevention of HPV infection in young women is important. Widespread HPV testing, care of pregnant women with chronic HPV infection, and delivery of HPV vaccine to the infant within 24 hours of birth, and safe and adoption of safe delivery practice will go a long way in preventing mother-to-child transmission of HPV. If we look at the status of the population who is aware of their hepatitis infection, it is only 5% all over the globe. The WHO aimed to increase the awareness about their HPV status is by 90% by the year 2030. Effective treatment is available for both hepatitis B as well as hepatitis C infection, and WHO aimed to increase the coverage of treatment by at least 80% by the year 2030. So this is the WHO target to achieve 90% reduction in the incidence of HBV as well as HCV infection and 65% reduction in the mortality due to these infection by the year 2030. This is the last oncopathogen which I'm going to discuss, and this is the H. pylori infection. So H. pylori infection leads to superficial gastritis, which if untreated can lead to atrophic gastritis, which if not treated on time can lead to intestinal metaplasia, dysplasia, and ultimately the carcinogenesis. There are various virulence factors that are associated with H. pylori, and that is why H. pylori is known to be oncogenic pathogen. This is the predicted incidence of gastric cancer world over by the year 2040. And if you can see clearly, majority of gastric cancer are in Asian countries. The incidence of gastric cancer is very low in the European as well as in North America and Central America. So what proportion of gastric cancers are attributable to H. pylori infection? These are the prospective as well as case control studies, and which have shown that around 85 to 90% of the gastric cancers are related to H. pylori infection. So how can we prevent gastric cancer? So primary prevention includes eradication of H. pylori. Various antibiotic treatment are available, which are of 7 or 14 days duration, which have shown to be effective in eradication of H. pylori infection. So these are 7 studies that looked at whether eradication of H. pylori infection leads to reduction in the incidence of gastric cancer, and later on a meta-analysis was also done, and which has shown that with the eradication of H. pylori infection by the use of antibiotic therapy, there is reduction in the incidence of gastric cancer, and the risk reduction ratio was 0.55. However, out of these 7 trials, 2 studies did not show any reduction in the incidence of gastric cancer with the eradication of H. pylori. And when it was looked back, it was found that in these 2 trials, number of cases who were included in these trials who had precancerous lesion at baseline was 100%. Therefore, a subgroup analysis was also done later, which have shown that eradication of H. pylori before the development of precancerous lesion offers the best protection against gastric cancer. So who to screen and when to screen? The magnitude of protective effect of H. pylori infection depends upon the baseline risk of gastric cancer in a given population. And it has been found that in population who has an incident rate of gastric cancer more than 150 per 100,000 person years, eradication of H. pylori and screening for H. pylori infection in this population has found to be cost effective. Screening and eradication of H. pylori before the development of a precancerous lesion, which are atrophic gastritis and intestinal metaplasia, is found to be most cost effective. So how do we screen for H. pylori infection? For mass screening, the non-invasive tests are preferred like urea breath test and H. pylori stool antigen test. Surveillance endoscopy is recommended for population who is at high risk for gastric cancer, at that high risk defined by old age, male gender, family history of gastric cancer in the first degree relatives, serum pepsinogen level serum pepsinogen ratio 1 and 2 less than 3, and cigarette smokers. So do we need surveillance endoscopy even in population who has undergone treatment for H. pylori infection and where H. pylori has been eradicated? So this is a systematic review and meta-analysis that was published in PLOS in 2019, and which have shown that in the population where there is an evidence of precancerous lesion, even those who have been eradicated, those who had achieved eradication of H. pylori, surveillance endoscopy is required, and it has shown to reduce the incidence of gastric cancer. So secondary prevention includes treatment of H. pylori infection in patients who have already developed early gastric cancer, which was limited to mucosa, and those who have undergone curative endoscopic resection, does treating such patients with antibiotic for H. pylori reduces the incidence of gastric cancer or not? So this question was answered by these 3 trials, which looked at the secondary prevention against gastric cancer, and it is found that there is a reduction in the incidence of gastric cancer with the use of therapy for eradication of H. pylori, even in patients who had developed gastric cancer, which was early stage. Tertiary prevention includes surveillance endoscopy, which is recommended to be done every year in patients who are treated for gastric cancer, and this is done to diagnose relapse at an. So this is done to diagnose early relapses. So to conclude, there are well-defined strategies to reduce infection-related cancer. Vaccination against hepatitis B virus infection has proven to be effective. Possibly in future, vaccination against HPV infection will also prove to reduce the incidence of invasive cervical cancer. Screen and treat approach, this is particularly true for HPV-related cancer, and that has found to be effective in reducing the incidence of cervical cancer. Effective treatment for oncogenic pathogens, predominantly H. pylori infection, HBV infection, and HCV infection, has also proven to be effective in reducing the incidence of infection-related cancer. Therefore, the focus of research in low-middle income countries should be on basic translation and implementation science, because it has a potential to reduce the incidence of infection-related cancer. Cancer prevention program should be targeted for the high-risk population, because in this high-risk population only, these cancer preventive strategies has found to be cost-effective, and they have the potential to reduce the cancer incidence and mortality. Thank you very much for your kind attention, and if there are any questions, I'm happy to take that.
Thank you, Dr. Seema. That was a very nice talk, very informative. We'll go on to the question and answer session. So, एक question आया था chat box में, which was about pancreatic cancer, and why is pancreatic cancer so deadly in comparison to others, and early detection is impossible. So, will you take that question, ma'am? तब तक मैं answer कर देती हूँ. मैंने थोड़ा बहुत chat box में लिखा था. See, pancreatic cancer is a cancer जो थोड़ा सा, okay, ma'am आ गई है. So let's. Good afternoon.
Hello. Hi, Mansi. Thank you so much.
How are you?
Yeah, I'm fine. Thank you.
Right, ma'am. So that was an excellent talk.
Thank you so much.
So we're on to the question answer sessions, ma'am. The first question tha, that was why is pancreatic cancer so deadly in comparison to others, and early detection is impossible. So it's technically not infection causing infection related, but आपके thoughts?
Yeah, so pancreatic cancer is basically, it remains asymptomatic in the earlier stage. That's why it is not picked up early. And pancreatic cancer, when it present, it usually involves the major blood vessels. And we all know that when major blood vessels are involved, then surgery becomes difficult and R0 is difficult to achieve. And there are no well-defined screening tests which have proven to be effective for pancreatic cancer. So I think these are the 2-3 main reasons why it is so deadly and we can't pick it up early.
Right, ma'am. The second question is, can a person take HPV vaccination if he's HPV infected? Any age limit?
Yes, so recommended age limit for taking HPV vaccination is ideally between 9 to 14 years of age, when a person is not infected with HPV, because all the previous trials and various retrospective analysis have also shown that if a person is infected with HPV, then the efficacy of the HPV vaccination reduces significantly. So the ideal age should be 19 to 14 years before before HPV infection occurs. And as I have shown in my presentation also, that from the Swedish health registry data, they have found that girls who are vaccinated before 17 years of age, they also had a better protection. So it's ideally before the onset of sexual activity, if HPV vaccination is done, that is the best way.
Okay. And ma'am, what about hepatitis B? So a question is, can a person take hepatitis B vaccination if he's hepatitis B a virus infected, any age limit? So that's a very interesting
And
question.
if person is already infected with hepatitis B, then hepatitis B vaccination is not going to help. In that case, we have to stress that the person takes hepatitis B treatment. And nowadays, there are very well, highly effective antiviral agents available that have kept the hepatitis. We can think like hepatitis B, hepatitis C, both can be cured with antiviral therapy.
Right. I think that's the most important point कि we have good medicines, अच्छे दवाइयाँ हैं cure करने के लिए और screening बहुत जरूरी है. Let's see. What is the outcome of breast cancer after surgery and chemotherapy?
The outcome of breast cancer depends upon what is the stage at which patient present to us, and the outcome also depends upon what type of breast cancer a individual is having. Breast cancer from treatment point of view, we divide into three main types: hormone receptor positive, triple negative, and HER2 positive. So outcome is different depending upon type of breast cancer as well as stage of disease.
And the next question is again, it is not infection related, but what is the main cause of thyroid cancer and what are the chances of reinfection even after RAI therapy?
Thyroid cancer is not infection related. Reinfection means, recurrence of thyroid cancer can happen even if radioactive iodine therapy. That will also depend upon the stage, what is the type of surgery done, whether R0 was achieved or not. So there are many factors that affect the recurrence rate here.
And okay, one question is, we were not aware. I think this is more of a comment which I'll read out. We were not aware that viruses like HPV and protozoans like Plasmodium falciparum are also linked to cancer, and vaccination plays crucial role in minimizing the disease. So I agree that yes, this is very important. इसीलिए आज हम ये वाला talk कर रहे हैं so that सबको पता चले कि इन्फेक्शंस भी कैंसर कर सकती हैं, स्पेसिफिकली जो मोर कॉमन इन्फेक्शंस है जैसे डॉक्टर सीमा ने बताया था, एंड कुछ में वैक्सीन करने से काफी अच्छा प्रिवेंशन होता है. Ma'am, next question is, why gallbladder cancer is asymptomatic in earlier stage?
See, early stage means it is limited only to the gallbladder, mucosa and submucosa, and it is gallbladder is like a bag. So in early stage, it is asymptomatic. Once the stage of the disease increases and it start involving other surrounding areas, then only it becomes symptomatic.
ये थोड़ा therapy related question है. Why is estrogen test not done after breast cancer so that tamoxifen can be stopped? How long should tamoxifen be given if hysterectomy is done? I think this is a very specific question. I think for one particular patient, I guess.
Yeah. So, estrogen test, there is no estrogen test as such. We do look for estrogen receptor status in the breast cancer. And if estrogen or progesterone receptor is positive, then only we advise them to take hormone therapy. The hormonal therapy could be either tamoxifen or letrozole, depending upon the menopausal stage of the patient. If a patient is premenopausal, we advise them to take tamoxifen, and if the patient is postmenopausal, we advise them to take letrozole.
Fantastic, yes, ma'am. Okay, this is a related question. What are the early signs of HPV infection and age of vaccination? Age of vaccination, I think आपने अभी बताया था.
Yeah.
And early sign of HPV infection.
So HPV infection can present as itching or white discharge. And I also told in my talk that nowadays it is recommended that whenever we are doing screening for cervical cancer, we should always do HPV DNA testing for high risk viruses. Based on that, then we can plan the further strategies, what is to be done next.
Right. This is a Hodgkin's lymphoma related question. What are the chances of recurrence of Hodgkin's lymphoma?
So the recurrence depend upon the stage of Hodgkin lymphoma, whether stage 1 to 4, the recurrence chances will differ.
Right, and that I think treating doctor जो होंगे वो आपसे definitely discuss करेंगे कि आपके chances कितने हैं, I guess. Okay, okay. What are the common names of these HPV, HBV, etc. cancers?
So HPV related cancer could be cancer of the cervix, other anogenital tract. HPV can cause head and neck cancers. HCV, that is hepatitis C virus, can cause liver cancer, which we call it as hepatocellular carcinoma. HBV can also cause hepatocellular carcinoma. H.pylori can cause gastric cancer. There are other viruses like Epstein-Barr virus that can cause non-Hodgkin lymphoma. It can cause Burkitt's lymphoma. So there are up to 11 to 12 such pathogens are available, there, which can cause cancers. I have stressed my talk only for 4 because the most common, more than 90% of the infection-related cancer are caused by these 4 viruses.
Right. One question, is blood cancer curable?
Yeah, blood cancer is curable depending upon what type. There are different kinds of blood cancer, what type of blood cancer an individual patient is having. Based on that, it can be cured.
ये थोड़ा सा therapy related question है. I'm suffering from carcinoma pancreas. Taking lemon helps in reducing cancer. Should we take lemon or not?
I mean, there is no evidence that taking lemon or any other dietary factor will reduce the chances of recurrence or prevent the cancer. We should all have a healthy, balanced diet, and we should do regular exercise.
Healthy diet, balanced diet, and good exercise. And I think ये सारे cancers में ही almost कहते हैं कि ये सबसे जरूरी चीज है. Okay, so again, similar question जो सबसे पहले वाला था. Why is ovarian cancer called a silent killer? Is there any infection causing it?
Yeah, so ovarian cancer is also known as silent killer because there is no screening test available, and it also remains asymptomatic. The most common symptoms of ovarian cancer are loss of appetite, some abdominal discomfort, which many patients do ignore, and majority of them present to us in stage 3 and stage 4.
Okay. What is the other risk factors other than HPV infection? This question I didn't understand. I think a risk factor for most likely cervical cancer ka hoga, other than HPV infection, particularly if the woman is virgin. I mean,
See, more than 90% of this cancer of the cervix are related to HPV, and more than 70% are because of 2 strains, HPV 16 and 18. And there are few subtypes of cervical cancer that we do not see nowadays, but earlier that used to be prevalent. If a mother is taking some teratogenic drug, then a child can have, but that also happens after 20 years of age. And nowadays we are not seeing those cancer because every obstetrician is aware that certain all teratogenic drugs should be avoided during pregnancy.
Yes. Okay. Should it be mandatory for all teenage girls to have HPV vaccination?
No, it is not mandatory. What I want to stress here is that there are there are many studies, but 4 important trials that have shown that vaccination with HPV definitely reduces the precancerous lesion. And there is only one study till date, which is a health registry from Sweden, which has shown that vaccination reduces the incidence of invasive cervical cancer, right? But the long-term data is still awaited, and in India, it has still not been adopted as a part of national immunization program. And our Tata Memorial Center was also a part of vaccine trial, which was kept on hold in between because there were few side effects with the drug, with the vaccine. Until that resolved, the trial was on hold and it has been restarted again. So we have to wait for another maybe 5 to 10 years that will give us a robust data whether vaccination really reduces the incidence of invasive cervical cancer.
इसी के साथ एक फॉलोअप क्वेश्चन है, बिकॉज हमारे पास भी ओपीडी में काफी पेशेंट्स आते हैं, पूछते हैं कि डॉक्टर साहब हमारे बच्चे हैं, छोटे बच्चे हैं, क्या हम उनको वैक्सीनेट करवाएं या नहीं करवाएं. सो ये क्वेश्चन काफी कॉमनली पूछा जाता है. सो आई थिंक आपकी क्या ओपिनियन होगी कि यस हम करवाएं या यस कि अभी वेट एंड वॉच करें.
You can suggest them that, see, these vaccines are costly. Each vaccine will cost around 3,000 rupees, and the recommended is 3 doses, 0, 2 and 6 months, but 2 doses is also enough. There are few trials which suggest that 2 dose gives equivalent result as compared to the 3 doses. So yes, we should educate them that there is a vaccine available. We know that it prevents precancerous lesion. We do not know whether it really reduces the invasive cervical cancer, but along with the cervical, suggestion regarding cervical cancer vaccine, we should educate them regarding safe sexual practices.
Right.
That is most important.
Do government hospitals provide injections at subsidized rate?
No, it is not available in any government hospital. It is not available in Tata Memorial Hospital as well. So if they have to take it by their own from the private setup. And nowadays, in fact, there is a shortage of HPV vaccine world over.
Thank you, ma'am. इसमें लिखा है kindly share some early symptoms of HPV and HBV cancers.
So early symptoms of HPV related cancer was already suggested that it could be some HPV infection, can also present as itching or increased with white discharge. HBV related cancer is mostly hepatocellular carcinoma, and they mainly present with abdominal discomfort, loss of appetite, abdominal pain, and in advanced stage they present with ascites.
Right, fluid in the abdomen, right?
Yeah.
Ma'am, if someone has fever for the last 1.5 years, all tests are normal, CT, MRI normal, small ovarian cyst and mesenteric lymph nodes, is there any cancer suspect?
I mean, fever since 1.5 years. It is difficult to digest that. Still, we are not able to make the diagnosis. So only on the basis of this, that there are some cyst and some mesenteric lymph node, it is very difficult to take that call whether cancer is there or not.
Right.
If any, the full history, what other tests have been done, and based on that, the decision can be made. And basically, the investigation plan need to be made before we can say that whether cancer is there or not.
एक ये क्वेश्चन है, how to prevent liver cancer when someone is suffering from chronic liver disease?
So we have to screen for HBV and HCV status. We have to regularly monitor the whether there are any nodules which are forming within the liver, which patient are advised to undergo routine ultrasound scan to look for any development of any nodules which are suspicious for malignancy.
Okay, I think that's it. एक है कि generally said that acidic medium for longer durations in our guts results in cancer. Is this true or just a misnomer?
No, it's not true.
Right. So I think in the end, एक ना बीच में कमेंट आया था कि थोड़ा हिंदी या पंजाबी. So पंजाबी I'm not sure, but एक मैम छोटा सा टेक होम मैसेज आपकी तरफ से जो लोगों जो यहाँ पे हिंदी स्पीकिंग जो हमारी यहाँ पे ऑडियंस है, आज जो हमने प्रेजेंटेशन करी है.
Yeah, so एक बहुत इम्पोर्टेंट चीज जो है वो ये है जिसको हम इग्नोर करते हैं कि इन्फेक्शन से कैंसर नहीं हो सकता, इन्फेक्शन से भी कैंसर हो सकता है. तो हमें सबसे इम्पोर्टेंट जो ध्यान रखना है वो यही है कि हम जो भी इन्फेक्शन रिलेटेड कारण है कैंसर होने के, उनको या तो ट्रीट करें टाइम पे या उनको अवॉइड करें. It's difficult to speak in Hindi, especially the medical something related to medicine.
I think भाई जैसे मैडम ने कहा, आपने कहा सबसे जरूरी है कि हमें पता होना चाहिए कि कुछ इन्फेक्शंस करते हैं, कौन सी वैक्सीनेशन जरूरी है. जैसे हेपेटाइटिस बी है वो तो लगवानी है. एंड कोई भी प्रॉब्लम होती है, कुछ भी नई चीज होती है तो आके जरूर हमें दिखाइएगा, वो सबसे जरूरी है. आई थिंक.
Yes.
एक last question है. What are the day-to-day practices one should follow to avoid infection-based cancers?
So you have to take care of cleanliness. You have to have balanced, healthy diet. Do exercises. You should have safe sexual practices, and you have to take vaccine and treat at the right time.
Yes, ma'am. So thank you, Dr. Seema. I think that was a very nice session. I think आज काफी लोगों के काफी सारे जो questions थे, queries थे, cancer related अच्छी तरह address हुए हैं. कुछ और questions हैं. Anyways, आगे अभी sessions चल रहे हैं, तो वो हम chat box में answer करते रहेंगे. And we'll move on to the next session. Thank you, ma'am, again.
Thank you, Mansi. Thank you so much.
Take care. जो हमारा नेक्स्ट वाला टॉक है वो ओबेसिटी एंड इट्स कैंसर लिंक्स है. जो स्पीकर हैं वो डॉक्टर उल्लास बत्रा हैं, who is from Rajiv Gandhi Cancer Institute, and moderator is Dr. Pankaj Goyal, who is also from our hospital. Without further ado, I'll ask Dr. Pankaj Goyal to take over. Thank you.